So bottom line, I think there are X chromosome effects that are very pro-inflammatory that lead women to getting more autoimmune diseases, and I think that's true for both MS, lupus, rheumatoid arthritis, etc.
Half of our population is above 50 and about 1/3 is females, peri and postmenopausal. And what about cerebrovascular diseases? This is also linked to menopause and hormones, but how does this affect MS?
It's debatable, but the first thing is just to show, as you said, could it be that both andropause and menopause lead to this aging phenomenon where they don't remyelinate like young people or mice, right? Hi, my name is Dr. Rhonda Voskuhl. I'm a professor, researcher, physician at the University of California, Los Angeles.
Hi, I'm Elisabeth Celius, neurologist and a professor at the University of Oslo and Oslo University Hospital, Norway, also doing research in MS.
And I'm Brett Drummond. You're listening to the ECTRIMS Podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. If you were to ask people on the street one thing that they know about MS, a common answer would be that it is a disease that affects more women than men. Indeed, the ratio is about 3-1. But whilst this fact has been known for a very long time, our understanding of the reasons behind this, and if and how sex-specific processes may impact on disease progression, and the symptoms experienced by women living with MS, are still hot topics of research. My guests on today's podcast, Rhonda and Elisabeth, have been instrumental in helping find answers to these questions. Rhonda, Elisabeth, thank you for joining me.
Thank you for having us.
Thank you.
So I guess let's start at the very beginning of the story. As I said, we know that women seem to be more susceptible to developing MS than men. What has research told us about why this may be? Rhonda, maybe I'll start with you. I know this has been a question that you've been looking into for a long time now.
Yes, I think it's important to do just as you have, and that is to split apart actually the susceptibility to MS and the progression of MS disabilities. And so focusing on the susceptibility, it's noteworthy that MS affects women more, but also it affects women more for rheumatoid arthritis, lupus, several other autoimmune diseases. And so we've hypothesized, and I think many have for a long time, that autoimmune diseases, affecting women more frequently could be due to, of course, sex hormones or sex chromosomes. And in our case, we've studied pretty extensively both, but with respect to susceptibility, we have publications that there is an X chromosome gene that escapes X inactivation. And so you get 2 copies in females and 1 in males. And in models of both MS and lupus, these 2 copies of X can be pro-inflammatory. And so then we've gone on to map that to an X chromosome that escapes X inactivation, and one of those is KDM6A. It probably acts, or we've got evidence that it acts through mechanisms whereby it's a known histone demethylase. That means that it changes transcription of genes genome-wide. So this is how you can have an X chromosome gene escape X inactivation and then have broad ubiquitous effects on the entire genome expression. So we did this in the MS model, CD4 T cells, and showed that it was pro-inflammatory, knocked out this gene and showed that it was better. So bottom line, I think there are X chromosome effects that are very pro-inflammatory that lead women to getting more autoimmune diseases, and I think that's true for both MS, lupus, rheumatoid arthritis, etc.
Elisabeth, I know this has also been an area that you've been interested in.
Yes, and I think Rhonda said it very well. The other question is to which extent the hormonal differences between the sexes do, but more probably that will affect the way the disease progresses and not susceptibility. So we'll probably get back to that.
Probably a good linking time to do it. I mean, let's talk then about how these seem to affect disease progression, because while we know that women do seem to be more susceptible to MS, often we hear that the disease progression in men can be more aggressive. Can you talk to us about thoughts behind that?
I think it's lots that we really don't know about this, because we see, first of all, that young women mainly get MS after menarche. So MS before is very, very seldom. what happens with menopause is less investigated, but what we know is that men progresses perhaps earlier than women, but in the end, they are quite similar when they really get old. So to which extent the different hormones affects in the different phases is something we have to investigate further. I think we'll know too little. Perhaps you know a bit more than me, Rhonda, about the hormones. You looked into that.
Yeah. So I agree with Elisabeth completely that the progression probably is more related to the hormones, as she said. And we have a paper in Journal of Experimental Medicine in 2022. We wrote a review, and we also referred to a different publication that we had. And what we noticed, and what I noticed when I reviewed this, was that it's quite interesting that with respect to this really curious situation where women are more susceptible and yet men do worse, when you look at the timing of that worsening, it's actually in it when people are looking at MS trials that have been done primarily in people 18 to 50 or 18 to 55 in some of these many trials that have been done, and they start to look at really the placebo treated and to see if men are worse. And this is where this data is coming from. And so if you think about it, testosterone, which again, Elisabeth said, I agree, is very important, sex hormones. Let's talk about them. Well, they actually can be neuroprotective because the estrogens are known to be neuroprotective in a variety of models and systems. And of course, testosterone is converted to estrogen in the brain by aromatase. So you can imagine how both of these hormones, actually testosterone and estrogen, they're both neuroprotective. Now, why would you have a sex difference in progression? Well, what we put into our review in Journal of Experimental Medicine was that it can be because testosterone drops actually earlier at the age of 30. Andropause begins by dropping 1 to 2% per year from age 30 to age 75. So it's a very slow decline of testosterone, and you can imagine a slow decline in neuroprotection. However, women actually maintain their estrogen quite a long time up until menopause. So they maintain estrogen pretty well up until age 51.5 is the average, but of course it ranges from 48 to 54. But imagine that. So men are starting to lose their neuroprotective testosterone at the age of 30 to 35 to 40 to 45 to 50. And I like graphs, but you can imagine that. And while women are maintaining their estrogen pretty well, and as indeed that time whereby we showed doing substructure brain atrophy that men are doing worse, both clinically and on substructure atrophy. But the ages that are examined are always going to be before age 50. Now, what happens after age 50? Well, lo and behold, many people have shown, actually, the Harvard group has shown this. There's good evidence by the Mayo group that what happens after 50, when women go through menopause, you have an abrupt loss. It's even more severe than that gradual loss of testosterone in men. And sure enough, women do worse. The disabilities are known to worsen with menopause. And so I believe, and what's in the graph and what I think the data shows when you review it, is that this temporal difference in the timing of loss of testosterone very slowly throughout from 30 to age 75 creates a situation where testosterone is lower than really, you can imagine, natural estrogens at ages before 50, but then after 50, boy, women have lost it all right after 50 to 70. Now, of course, as Elisabeth said, when they're 70, it's really all evened out. Neither one of them have hardly any neuroprotective hormones.
Mm. Well, and that links a little bit to symptoms, I think, because I know that one of the things we talk about with men with some of this decline is deficits in cognition. And I know from previous conversations we've had that cognition is something you're particularly interested in looking at around the time of menopause in women living with MS. Can you expand on that a little bit?
Yeah, think about menopause in MS. You first have to really, and its effect on cognition specifically, as you asked, we should really think first about what does menopause do in healthy people without MS? What does it do to their cognition? And there's a lot known. So what happens during menopause in healthy women is that there are cognitive issues, specifically verbal memory and processing speed. So this happens in women that don't even have MS. And so we have to imagine that this could be deleterious for women who we know MS patients have cognitive issues. So now you've overlaid on top of that a situation where you've lost estrogen, it's neuroprotective, and it's known that even non-MS women have verbal memory and processing speed and some executive function deficits. Actually, it's been mapped by neuropsychologists, this deficit. So what we've pursued is the possibility that perhaps estrogen, if, again, that's tricky about the type, dose, timing, and age to give it. That's very difficult. But there should be a way to optimize the estrogen that could be given, whether it's a specific alpha estrogen receptor ligand or not, we can get into. But there should be a way to prevent this precipitous drop of estrogen ligation in the proper receptors in the brain in the area of cognition to prevent cognitive decline with menopause, and in both healthy women and in women with MS.
And I think also for women with MS, they are undertreated with hormones because lots of people are afraid of giving hormones to someone with MS and different degrees of handicap. And on the other hand, also symptoms of menopause are not recognized as that, but thought that this might be MS. And so I think they are really undertreated regarding menopause. So that adds also to the problems for women with MS.
Well, I agree with Elisabeth. I think they're undertreated. And I think the data comes from the Women's Health Initiative study, which was done, and we all know that those women were around 75 years old. You've got to treat early. It's a preventative treatment. You don't treat after the disease has already happened. Repair is very different than prevention. So it's widely considered that there's a critical window whereby you would treat with an estrogen, and it would have to be, probably within 5 years, it would be optimal, and then up to 60. And then after 65, you get into the situation where, it could be that your risks for things like stroke, cardiovascular disease become higher. It's always this risk-benefit ratio, but there's no reason we shouldn't be really thinking hard about finding a better treatment for women who are aged 50 to 65. And what we've been using is estriol, which happens to be an estrogen they're during pregnancy, and we all know pregnancy is good for MS. And we're not going to really go into that in detail, but estriol is a unique estrogen to pregnancy. We're very keen on it because it binds ER beta, and it doesn't really bind ER alpha hardly at all. It was thought to be a weak estrogen. That's because it binds ER alpha so weakly. I actually like that it binds ER alpha weakly, very weakly, because it's ER alpha that is in breast that promotes breast cancer. And this is some of the reason people shy away so much from taking and treating, as Elisabeth said, under-treating menopausal women because they're afraid of breast cancer and increasing risk for that. Well, that's why you need to not treat with something that binds ER alpha. It should bind to ER beta. So this is typical of even the interferons. We know that interferons have to be optimized for type. It's not gamma, it's beta. We know dose matters. We know type of interferon matters. We know timing matters. These are all true with estrogen. And so we can't merely give estradiol or Premarin and say, oh, well, it didn't work, or it's too much risk. There's too much risk. We should do like every other pharmaceutical company does and optimize for a receptor that can be neuroprotective, and that's ER beta, which we've shown in many studies, and other people have too, and then not, of course, stimulate ER alpha. So it's just maximizing efficacy, minimizing toxicity, and finding a better treatment for menopause, whether they have MS or they don't.
Yeah, and as you said, early treatment, not delayed because repair is difficult. It's prevention.
And I mean, that's exactly the motto that we're hearing in MS for all treatments, isn't it? The earlier we can get in, the better our long-term outcomes. So it makes sense in this case as well. And it's interesting that you mentioned estriol, having had a publication recently that's shown some really interesting and exciting data, both in terms of in a preclinical model, but being able to reduce EAE when given as a treatment, and also some potential to alter lipid profiles and promote remyelination. Can you talk us through that really recent data that is really interesting?
Sure. We've done, really a decade of work with estriol, with ER beta. The estriol showed it improved hippocampal synapse formation. In white matter, it causes remyelination. We have other papers showing it acts on both oligodendrocytes to increase cholesterol synthesis and myelination, so that's a direct effect on oligos. And then it also has an indirect effect by binding to microglia, and microglia are pro-inflammatory. They prevent oligos from remyelinating. So there's a multi-pronged approach whereby you can have increased remyelination in white matter and synaptic plasticity in hippocampal gray matter. Now, of course, you want to go past EA in preclinical models, and you want to go to MS. And so what we showed in MS is we haven't done ER beta ligand trials because they really are in the preclinical stage. They need development first to go to patients. But what we did is we did 2 phase 2 trials of estriol in MS patients. The original was just 10 patients and showed a soft, I would say a subtle anti-inflammatory effect, adding it onto Copaxone years ago and showing that it reduced relapses by 1/3 further, and it reduced enhancing lesions. But what the bigger trial was, of course, and we have 3 papers on it now, and that was the Lancet Neurology paper showing that when we treat it, it's a phase 2 trial of 178 patients. And what we showed that estriol, as compared to placebo treatment, people with MS, they had improved cognition. And so I was really excited about that. So it wasn't a decrease in decline, it was an improvement. And by the way, it was as compared to the placebo controlled. So it wasn't a practice effect because the placebos were practicing just as much. So it was really exciting to see this improvement in cognition. And it reminded me of data in rats and mice. When you take away estrogen, they have cognitive decline. When you give it back, they have synaptic plasticity and more hippocampal synapses, which is what we saw in EAE. So that was really interesting. The other interesting thing was not just the clinical outcome of having improved cognitive testing. It was, and that was specifically processing speed, but we really didn't go into all the domains. And I'm pretty sure verbal memory would have been affected, but we didn't go through that at that earlier time point. But the other 2 cool things was, one was that we had sparing of brain atrophy, but again, it's localized gray matter atrophy. It's not whole brain. These things have to be regional and specific to the estrogen receptors that are expressed. So what we found was there was sparing of gray matter atrophy. It was regional. There was sparing in regions known to be involved in cognition, like frontal cortex. And the last thing, which was a paper in 2022, was we looked at serum NFL. So NFL has been known to be a marker aligned with actually aging, neurodegeneration with aging. So we thought that was particularly interesting because of what we said before with menopause. So we gave estriol versus placebo, and in that same trial, when we looked at the blood levels of serum NFL, we showed that estriol treatment at 12 months decreased serum NFL as compared to the placebo treatment. So we've got, clinical, we've got MRI biomarker, and now we've got serum NFL that are all indicating protective effects of estriol treatment in MS women, and the dose is really an 8 milligram mid-pregnancy dose.
That's very interesting and very promising, I think, for women.
It is what we have now, and people submit trials. We just submitted a trial to the NIH. And it's 7 sites across the United States, and who knows if it'll be funded. It's the first time in, but I think it is exciting because what we've done is we've combined the things we talked about so far on this program, and the design is actually to treat menopausal women with estriol, and again, it's that, like Elisabeth said, it is, the ages are, perimenopause to 65 maximum. Really, we prefer 60 to go in there and treat. And actually, just to show what she said that's important is the negative control that I chose, again, just for the trial, is actually low-dose Premarin, because low-dose Premarin is just a very low dose of a mixture of a lot of different estrogens. And I don't think it's good enough when you review the data on healthy menopausal women and what people have looked at for brain atrophy, functional connectivity, and so forth with menopausal women. I think you've got to have the right estrogen, the right dose, the right timing, and all this together. I've actually got estriol 8 milligrams as my positive, as my test case, and the negative control is actually low-dose Premarin, because I think you have to have a sufficient level actually to get neuroprotection, which we showed. The improvement in cognition correlated with estriol levels in the blood. So dose matters and blood levels matter. I don't think any little, Premarin's going to work. I don't think it's going to be that easy, just like it's true for many other drugs in MS. Dose matters.
Dose and timing.
Dose and timing. Type, dose, timing, age, all these things matter, but they're doable.
What's interesting as we consider, hearing about the remyelination potential of some of these, and knowing that remyelination and the potential to remyelinate drops over time in people living with MS, and aging seems to be something that we're really putting that down to. And then tying this in with hearing, the sex hormones are obviously decreasing as we age, and then there's this big drop off. Do you think there's potential that sex hormones are a big, and drop in sex hormones are a big reason why we start to see a failure to remyelinate over time?
I think that's the case because there's a group that's done a lot of work in France, and they've shown work whereby testosterone can cause remyelination. And whether it's through androgen receptor, I think they've got some androgen, they think it might be, but it could also be estrogen receptors. It's debatable, but the first thing is just to show, as you said, could it be that both andropause and menopause lead to this aging phenomenon where they don't remyelinate like young people or mice, right? So I think so. I don't know. Elisabeth, what do you think?
No, I agree with you. I think this is very interesting and something that we really need to explore.
Well, I mean, lots of interesting stuff happening in that space. Are there other areas of research specifically related to the lived experience of women with MS that you're particularly interested or following at the moment?
I think also this, we know too little about comorbidities in the aging population. So aging, talking about, yes, the time from around menopause and further on, and that is very many patients. Half of our population is above 50 and about 1/3 is females, peri and postmenopausal. And what about cerebrovascular diseases? This is also linked to menopause and hormones, but how does this affect MS? And I think they are again undertreated because you see their MS and you're caring about the MS and you're forgetting about the rest. So I think it's a big area that needs to be explored, and everything is linked together here. And the common, perhaps main problem is the decrease in hormones. But it really affects the life of women with MS.
Rhonda?
Yeah, I'm interested in the role of sex chromosome genes, not only in immunomodulation, but we're looking at XX versus XY gene effects in microglia, because it is the resident immune cell in the CNS. And so we're submitting a paper about this KDM6A, the X chromosome gene that regulates genome-wide transcription. So we're looking at the effect of having 2 X's in microglia as compared to 1, and could this be pro-inflammatory? And it could be relevant to Alzheimer's disease, MS, cognitive decline, and aging. I always think about this kind of yin-yang relationship between sex hormones and sex chromosomes, whereby XX is pro-inflammatory and then estrogen's anti-inflammatory. So I'm interested in moving some of that from the immune system into the CNS, the immune reactions that happen in the CNS.
It's all incredibly interesting. Well, I guess to finish off as the last question, and I think we probably have a pretty good answer as to what this might be based on our discussion so far, but for women living with MS that might be listening to this podcast, what do you think or hope will be the next big advancements or findings that will either help them or enable us to better understand the sex differences that occur in MS? I'm thinking the results of an estriol trial will be very high up on that for everyone here, but anything else on there?
Yeah, for me, it's the estriol trial to help not only menopausal women with MS, and that's going to be to prevent disability accumulation and brain and localized brain atrophy, but also I do believe that treatments to block X chromosome gene effects. And for example, metformin has been known to be able to antagonize KDM6A. So, and that's just something that's off the shelf available, and that we're studying its mechanism. Metformin does a lot of things, but if it could interfere with this X chromosome gene, that could be deleterious in some of these pro-inflammatory responses. So again, I think treating with the proper hormone to enhance these good neuroprotective things, and also maybe to block some of these X chromosome gene mechanisms that could be, metformin could be a low-hanging fruit, but we could obviously develop better specific ligands for KDM6A.
I mean, we discussed metformin in a previous ECTRIMS podcast episode with the researchers from the University of Cambridge who are currently doing the remyelination trial with it. So really interesting. Elisabeth, what about for you?
I think in addition to the basic knowledge that we really need and that Rhonda mentioned, increased awareness and information and interest in females and in the aging population will be an advantage for the patients. As I have said, that I think they are undertreated to a great extent and perhaps also partly wrongly treated. So to increase awareness and knowledge will also help while we are waiting for more basic knowledge and improved specific treatments.
Yeah, I think I want to expand on what Elisabeth said. So I was president of the Organization for the Study of Sex Differences, which is the international organization that really embraces biologic effects between females and males. And instead of lumping them together and assuming, you get variability when you put them together and you don't study them separately, you just get variability, and that drives up sample sizes. And so the idea is, years ago, neuroscientists always studied male mice. They, and a lot of doses and things were designed for males. The dose of aspirin for heart disease, and then you just assumed it was going to be the same for females. The dose of Ambien for sleep and the drowsiness effects. So there's been an initiative by the National Institutes of Health, of course, to require all grants to consider both females and males, which is what I think Elisabeth is also alluding to, is you can't just study one sex and assume it's true for the other. And that's vice versa. So you can't study things just in females either and assume the same dose, timing, et cetera, is going to be true for men. And so I think it's a way to get invaluable clues to, what makes the disease better or worse by seeing the sex difference and then expanding and exploring on that. And it's going to help women and also men. So it's just that women have been a little bit under recognized in their difference with men, as she alluded to.
Well, I think we can safely say that with the two of you looking into this, that's something that will be changing and has already changed due to your efforts. Thank you very much for the podcast today. It's been incredibly interesting and so fantastic to hear you speak about all of the research that's going on, but also the passion that you have for this field and speaking really passionately about it. It's really fantastic to hear.
Well, thank you, Brett. We need men like you to bring it forward. We really appreciate you.
Yeah, thank you both for bringing it up.
So thank you, Rhonda and Elisabeth, and thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode. I'm also co-founder of MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS Podcast is produced and hosted in collaboration with two key partners, MS Translate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The ECTRIMS Podcast is supported by an educational grant from Novartis, Roche, and Alexion AstraZeneca Rare Disease. Educational grant providers have no input on the podcast series content. You can read more about the topic of this latest podcast and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS Podcast on your favourite podcast channels and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.